This is a strategic briefing for investors and policymakers evaluating the structural future of global healthcare. We are detailing a specific technological intervention designed to intercept global health crises at their origin, while simultaneously operating as a highly scalable passive income asset. The biology of an outbreak dictates that pathogens spread through communities long before a patient feels sick enough to travel to a clinic. By the time severe symptoms present, that individual has already spent days interacting with coworkers, family members, and service workers as an asymptomatic or mildly ill vector. The only effective window for halting community transmission exists strictly in this pre-hospital phase. Missing this window ensures the pathogen will circulate freely through the population, overwhelming the local health system entirely. The most urgent threat exploiting this structural failure is antimicrobial resistance, or AMR. This chart visualizes the global baseline from 2019. AMR was directly responsible for 1.27 million deaths and played a role in nearly 5 million more. That death toll exceeds the annual fatalities from HIV/AIDS and malaria combined. Epidemiologists project that, without systemic changes to how we triage patients, drug-resistant infections will cause up to 39 million annual deaths by 2050. These pathogens are not confined to isolated research labs. They are highly prevalent, actively circulating strains, endemic to our local clinics and communities. AMR is an active, compounding crisis, already extracting a massive financial toll on the global healthcare infrastructure. We operate under the assumption that hospitals are safe havens, but their physical layout actively works against basic infection control. Traditional triage forces all incoming patients into a single bottleneck, the waiting room. Here, highly infectious individuals are seated shoulder to shoulder with the elderly and immunocompromised. High-touch environmental vectors, chairs, shared magazines, and reception desks serve as physical reservoirs, facilitating rapid microbial exchange between patients. Prolonged wait times multiply the exposure dose. The longer a vulnerable patient sits in this environment, the higher the probability of colonization. By funneling the general population into these dense, stagnant environments without a prior filter, hospitals actively amplify the spread of the exact drug-resistant infections they are trying to cure. The structural flaw is the absence of a decentralized pre-triage gatekeeper, a system to filter patients before they cross the hospital threshold. The average citizen lacks the medical literacy to self-triage. When a fever spikes, they cannot accurately determine if they need over-the-counter medication, home isolation, or an emergency room. Healthcare conglomerates have invested billions into digital symptom checkers to solve this, yet hospital congestion remains at record highs. Standard AI relies on rigid, statistical decision trees. To avoid legal liability, these algorithms are programmed to default to maximum caution. If a symptom presents even a fractional risk, the app directs the user to see a doctor immediately. The result is massive over-triage. Clinical data shows that 76% of emergency and primary care visits are unnecessary consultations. Liability-driven algorithms generate patient panic, drive unnecessary demands for antibiotics, and completely break hospital throughput. Dr. Maya AI utilizes a different architecture entirely. It abandons statistical decision trees for pattern-matching heuristics built on 40 years of human clinical triage experience. Rather than escalating panic based on a single symptom, the system analyzes combinations of symptoms to evaluate the patient's complete clinical story, exactly as a senior physician would. The AI translates these complex clinical patterns into a simple 4-quadrant color-coded logic matrix, providing immediate, actionable guidance. 3 pathways handle non-infectious cases: red for severe emergencies, green for routine appointments, and yellow for safe, guided home care. The critical intervention lies in the blue quadrant. When the AI detects a combination of symptoms indicating a high infection risk, it issues a mandate for immediate isolation at home prior to any clinic entry. By safely diverting the worried well and immediately isolating the contagious, the system neutralizes the primary driver of AMR spread. A sophisticated AI cannot protect public health if it is restricted to smartphone applications, completely bypassing populations with low digital literacy or limited internet access. This gap is bridged by the physical Prima kiosk. It is a standalone, multilingual primary care terminal engineered for deployment directly in remote and rural villages, local community pharmacies, and busy factory floors. A symptomatic individual interacts with the kiosk in their native language, inputs their symptoms, and receives a blue isolation directive on the spot. This localized, immediate guidance halts the transmission chain at the very point of origin, protecting the community before the pathogen can spread. The Prima kiosk transforms passive populations into an active, decentralized defense network against emerging outbreaks. Untriaged patient volume directly degrades the healthcare workforce, resulting in severe burnout and chronic physical exposure to resistant pathogens. Removing 76% of non-critical visits shields doctors and nurses from this daily exposure, preserving critical hospital capacity for genuine medical emergencies. At the macroeconomic level, the system slashes institutional waste, radically reducing the costs associated with missed appointments and overprescribed antibiotics. At the microeconomic level, the kiosk operates as a high-margin passive asset. Just 10 user interactions per day generates over £18,000 annually for the operator. The Prima architecture seamlessly aligns the preservation of critical health infrastructure with scalable, decentralized financial returns. Traditional pandemic surveillance is inherently reactive. It relies entirely on lagging hospital admission data to detect a crisis. A deployed network of Prima kiosks functions as a real-time surveillance radar. It identifies symptom clusters at the street level, flagging a potential outbreak days before local hospitals register a spike in admissions. We have seen the catastrophic human and economic costs of reactive outbreak management. Predictive containment avoids this entirely. Scaling this technology requires the immediate engagement of investors, venture capitalists, and policymakers to fund the global rollout of this essential infrastructure. The Prima kiosk and Dr. Maya AI provide the structural and financial firewall required to protect global populations from a post-antibiotic era.